Okay, so the last session I spent way too long talking about prenatal plan of safe care. And so I'm going to do a very brief kind of like level setting background on plans of safe care. We got a lot of that, I think, earlier this morning and this afternoon. And so after I do that, we'll just do like a quick poll maybe to see if people want to spend time in the prenatal space, the birth hospitalization space, et cetera. Hello, thank you for joining us. Okay, so just like we were talking about this morning, plans of safe care slash family support plan, family care plan, are in place to support families and babies impacted by substance use disorder. I think here in the state of Colorado, just kind of like set this landscape stage. Currently, plans of safe care kind of exclusively live in the child welfare Denver Health Department of Human Services space. But as a reminder, per the Administration for Children and Families, that a plan of safe care is imperative, whether or not there is a concern for abuse and neglect. And so I think just kind of reminding ourselves that any family actually can benefit from a plan of care that addresses the needs of the caregivers and the infant, and specifically families impacted by substance use disorder can benefit from that. And so reminding ourselves that currently, kind of as the landscape sits, any infant born with in utero substance exposure is not necessarily going to get a plan of safe care. The only babies as it is right now required are those for whom a mandatory reporter has a concern for abuse and neglect, calls up DHS or CPS and says, hey, I have a concern for abuse and neglect. And then the caseworker determines that there is a concern and they screen that call in. So of all of this entire kind of cohort of infants with in utero substance exposure, really only a small number of those are going to get a plan of safe care by DHS. And I think we can kind of all agree that we should be able to provide this service for all of our families, regardless if there is a concern for abuse or neglect. And so I kind of want to acknowledge before getting into this work that we should all kind of assume the best intentions of one another and of the families that we care for, and recognize that we are all here because we want to do the best we can to support these families, but also acknowledging that providing comprehensive, collaborative, thorough, trauma-informed care and support is super time and resource intensive, and requires a lot of folks coming together, and that can be hard, and that change is hard, time is a limited resource, and so that this work is tough. And I have been working in this space now for 3.5 years, and I feel like I have moved the needle like 0.5 millimeter at my birth hospital. And that's kind of the best I've been able to do. So it's really tough, but I'm glad we're all here because we all just want to take better care of our families. Okay. So I think one of the things that was really important, hi friend, one of the things that was really important when I was setting out to do this work in the Denver Health Newborn Nursery was kind of speaking to my colleagues and acknowledging that this is tough work, that there are a lot of barriers, that this is resource intensive, and just acknowledging that this is like not easy, because I think that sometimes, especially in the healthcare space, like to have more piled onto our plate, it just sometimes feels like is no one acknowledging how much we're already expected to do or already need to do or whatever. So acknowledging that, and then being really mindful of our own, what are we bringing to the table? What are our stigmas? What are our biases? And how are we thinking about this specific patient population? How are we talking about this patient population? How are we documenting about this patient population? So I think there are a couple really great resources that y'all can link from my sides. One of these is the interest form to sign up for the wait list for that stigma and bias training that CPCQC was talking about earlier. And I think Raquel, it sounds like maybe led at least some of those sessions. And then there's a great campaign called Words Matter that again is sort of similar to one of the slides from earlier this morning, that encourages person first language, and especially now with a lot of hospitals use EMRs in which patients have immediate access to the documentation that is put into their chart by providers, and so being cognizant about how we are documenting is really important. And then finally, one kind of thing that was helpful for me in getting some buy-in at least at Denver Health is figuring out who from your institution, from your community organization, who needs to be at the table, and then figuring out, okay, how can I go and find those people? And so for me, that meant emailing somebody within the outpatient pediatric department and saying, hey, when are your weekly or monthly staffing meetings? Can I have 15 minutes or 20 minutes to go to that staffing meeting? Talking to our prenatal care providers, our CNMs, our family medicine, OBGYN, saying, hey, when do you guys have provider meetings? Can I just come and chat for a little bit? And then also identifying champions or people interested in this work in your organization so that you have kind of allies and support in helping get this off the ground. Because again, it is I've been working in this space for very, very long, and it's still really, really tough to get folks to buy in and be interested. And so finding champions to kind of help carry the flag can be helpful. And then, this is a reminder that that QR code is a way that you guys can, that y'all can put your name and information and request more site specific or organization specific tips, tricks, whatever for plans of safe care that we can't get to in this 30-minute session. Okay, so these are a few places in which I just at Denver Health and now kind of starting this work at the university and elsewhere have focused on trying to engage with families impacted by substance use disorder, and kind of time points in which I have we have tried to implement plans of safe care. And so I spent forever talking about the prenatal piece, because I also feel like we've talked about that a lot today, is engaging families upstream. So I'm happy to focus on the prenatal plan of safe care that our plan of safe care work group with healthcare providers, folks from DHS, folks with lived experience, social workers, et cetera, have kind of weighed in on. I'm happy to go through what I have done during the birth hospitalization and barriers, successes, nitty-gritty details of integrating this into the EMR, or I can also kind of go in, it's a little bit less full of a space, but into the post-discharge stuff. So is there anything that would be of particular interest to y'all? I want to be mindful of time. Prenatal, birth hospitalization. I feel like those are the hot button issue or hot button topics right now. Okay, birth hospitalization or post-discharge. Yes. Okay. So let's talk about birth hospitalization stuff. Just as a quick FYI, I am happy to share. So this is our the prenatal plan of safe care that our work group helped kind of. I sort of made something up and then got input from Dr. Kaylin Klee, who is a family medicine provider, also has specialty in addiction medicine, who has a perinatal SUD kind of patient population at Denver Health. And so she has done this with her patients, gotten feedback from her patients. I've got feedback from folks with lived experience, and I have a template for this that is on paper and also one that could be put in your EMR. So if you guys are interested in that, it exists, just shoot me an email. And then have some kind of support on how you may be able to bill for the time that it takes to put that together. Okay. So in terms of birth hospitalization, I have primarily done this work at Denver Health, and then I have some colleagues who have started this work at the university's newborn nursery. I will say that both of those systems use the Epic EMR, and both of these plans of safe care live within the Epic EMR. But the way that the way that documentation occurs within Epic at those hospitals is different. So for those of you who have Epic experience, Denver Health, we do problem-based charting, and at the university, at least in the newborn nursery setting, you have a problem list, but then you just like free text willy-nilly into the actual note. So it's a little bit different styles. We have kind of figured out how to do it both ways. So if this is something you're interested in and you document one or the other way, happy to talk about that. In terms of like speaking generally, how did we go about getting folks on board and starting this process? Is education, cooperation, collaboration, like with everything in life. So I think one of the things that was really important for our group was educating the provider team, but also educating our families. And so in terms of what does education look like for our provider team, we were fortunate in Denver Health when I rolled this out is that we were a core group of like 6 pediatric providers who staffed the nursery. And so educating ourselves was really easy. These are like some of my best friends. And so it was a little bit easier to get buy-in. I want to recognize that Denver Health is a like perfect system for trying this out. And Lisa can attest to this. So most of our patients, our pregnant folks, are getting their prenatal care at Denver Health. Most of them are delivering at Denver Health. Most of their babies and the parents are staying within the Denver Health system for their care. Everybody uses Epic. And we generally have a core group of prenatal care providers, nursery providers, and then follow-up providers. And this was still excruciatingly hard, and it still is like not working well. So I just want to acknowledge that I have a perfect system in which to have trialed this, and it has it's like still really hard. So for those of you who are not working in that perfect system and are struggling with this, like props, because I have a perfect system and it's really, really tough. So just wanted to acknowledge that. But so education was really important, I think, for both our families and our providers. And so making sure that our pediatric providers and our prenatal care providers were aware, and our post-discharge providers, so outpatient pediatricians and outpatient postnatal providers, were aware that this thing is happening. What is it? And it didn't have to be an in-depth thing, but just hey, a plan of safe care is XYZ. You're probably going to start seeing this show up in your patient's charts. This is what to do with it. This is what it means. And then educating families that a plan of safe care will be completed during their birth hospitalization by their healthcare team. And then part of that is wrapping in education of families about the birth hospital expectation. So a lot of times, and I think Susan pointed this out with the chosen data, is that a lot of times families arrive into the hospital perhaps without prenatal care, or perhaps having received care and never really being talked about NOWS or NAS and what to expect for that. So really like during those, like that first day of birth hospitalization, talking to families about what to expect from the baby, what to expect in terms of symptoms, care, how they can support their infant and things like that. And then moving towards discharge readiness, expected length of stay, things like that. I also made sure that on the mom baby unit, our care managers, our social workers, had buy-in, had education, and kind of had the ability to update the plan of safe care. And so what that looked like is within our EMR, our social workers who were doing a lot of the needs assessments, they were doing a lot of the documentation around referrals that they were making. They were doing a lot of documentation around folks in the household. They didn't actually have the ability to update a problem list or write a note in the chart. And so I had to like call the Epic people and say, hey, I need this group of people in my hospital to have that ability. So that took time. And then making sure that the pediatric group also knew that when that baby was delivered, that we are not going to start addressing the plan of safe care the day that baby is ready to go home. This is a long process, and as soon as that baby is born, we need to start thinking about this and talking about it. And then a reminder, I think, again, that has been talked about today, is that babies who received a plan of safe care did not necessarily mean they were also getting a report by or a call into DHS. So I had families who the pregnant person and her partner had been in recovery and stable on MOUD for like 10 years, but had mental health needs and had follow-up appointments. Those families, like they get a plan of safe care, but there is no DHS involvement. We do the plan of safe care, our social worker and our team supports them. They walk away with that plan of safe care, never having interface with DHS because there was no concern for abuse or neglect. So that was like not an issue. So what this looked like, yeah.
When did the Colorado law change so that prenatal exposure alone did not substantiate child abuse and neglect?
2020.
Okay.
Yeah. So do you guys all have context for that question? Yes, most of you. So prior to 2020, a child or an infant was kind of considered by definition abused or neglect based on just positive biologic testing for substances. So just like Jade was saying this morning, that there is now a complete de-emphasis on toxicology testing and the focus is entirely on whether or not an infant is both threatened by and affected by in utero substance exposure. Okay, so kind of like tips and tricks beyond for the EMR based plan of safe care. So the like kind of nitty gritty nuts and bolts of that is at the time of delivery, an infant gets a history and physical or a note documented in their chart. And most of those babies, if they had in utero opiate exposure, would have a problem that says in utero opiate exposure. And in that, the healthcare provider details how we will take care of that baby based on their risk for NOWS. I had to figure out like, where am I going to put this plan of safe care document in a baby's chart such that everyone can see it. So what I figured out is that in Epic, which I suspect that there are similar things in other EMRs, there was a problem that you could put in this baby's chart that was plan of care discussed with family or care plan discussed with patient, something like that. I think I put it in here, care plan discussed with patient. And so I would put that problem, or the admitting provider, whoever was seeing that baby on day of life 0, would put that problem in that baby's chart and then put the plan of safe care such that it lived with that problem. And as a reminder for those of you who maybe were not at previous forums and have seen this template, this is what it looks like. So this basically would live in this baby's medical record, and then throughout the birth hospitalization, the pediatrician taking care of the baby, the social worker, care manager, whatever, would kind of go through and update that during that infant's course. And again, wanting to like emphasize the fact that this is not something that we would do on the day of discharge. This is something that would go in that baby's note day of life 0, and that the provider team taking care of this infant would update throughout the infant's course. And it was also helpful for some of our pediatricians who would rotate in, who didn't consistently take care of infants with in utero opiate exposure. There was kind of like a reminder of, is this baby physiologically ready to go home? And the things that we think about to assure ourselves that, yes, this infant is physiologically ready to go home. And that, again, is detailed on, I think that's on this kind of flow sheet that I talked about at our forum back in April. So this is like a quick tip sheet on birth hospitalization providers to start thinking about what components are in the plan of safe care and when we can move towards discharge readiness. So in terms of the EMR based plan of safe care, we had in Denver Health, we basically put it within the problem. And then some of the like issues we came in with that. How many of y'all have used Epic? So you know in Epic where you can like put the like 3 stars as a reminder to like, oh, I need to fill that in. I think it's called a wild card. So one thing we realized is that if you are filling out this problem, you can't click out of the problem list until all of your 3 stars are filled out. And so, but like when we are filling this out on day of life 0, I don't necessarily like, this baby is not ready to go home, so I can't check those boxes. So we had to create a system within our pediatric care providers in the nursery that like 2 stars meant like this still needs to be filled out. would let us close out the problem, but signal to whoever may be coming after you or discharging that baby that there are still things that need to be fixed. In the university nursery where they do not do problem-based charting, what the workaround that was found there is you basically have to create a progress note that you can then share, and then folks as part of the healthcare team then gradually go in throughout the hospital course, update it, and then hit share. That is also kind of like a clunky way to do it, but that was sort of the workaround that we were able to do within Epic without the Epic like gods fixing the entire Epic system, which I tried to do in 2020, and they were like, LOL COVID. And I was like, okay, I'll see you guys like in 4 years. So that this has been like our very like admittedly like janky workaround. But it's like we're making it work. And we have had like a handful of families who like one of my colleagues discharged a family from the university who was, they were more rural, and they were going to be going back to their family care provider or their family medicine provider who'd be taking care of their whole family. And this colleague of mine like printed out the plan of safe care and handed it to that family. And the mom was like, this is amazing. Like the mom was like ecstatic to have all of her information in one place that she could then just like take to her provider. Because the other, I think, limitation with Epic, again, Denver Health was this perfect, beautiful little model to try this out, because most of our babies were staying within the Denver Health system and would have that chart follow them until they left the Denver Health system. The university, though, in contrast, when we discharge babies from that university nursery, they are going to pediatricians all out in the community who oftentimes, they certainly don't have the university Epic system, oftentimes have different EMRs or completely different Epic systems. And so in those scenarios, that's when you have to print that plan of safe care out and hand it to the family. We have had we often will then fax it to the following pediatrician. Because Jade and I were joking, like, I am a newborn provider, and all I needed to do was like bring my son's newborn screen to his first pediatrician's visit, and I like forgot that, and like that is like my job. Like, this is what I do, and I couldn't remember that. So faxing this to your like, pediatric office of follow-up can be helpful. I want to emphasize and remind folks that when we are printing these out and giving them to families, that they have very sensitive information. And so I would often, we have like a redacting pin in the nursery. And so I would often like give that to the family, but redact the name, the medical record number, so that, like, heaven forbid, should that wind up like in the parking lot, that is not something that could be picked up. And then all of a sudden, like, Joe Schmo knows your entire history, all of your contact information. So one thing to be really mindful of, if you're going to go the paper route, I think that's great. It gives family like ownership, and they have a tangible thing that they can carry around, but that also comes with all of the baggage that comes along with paper. The other thing that we were able to do, at least in the Epic system, is if you want that to like live on, because for those of you who use Epic, as you can imagine, if a baby has like a progress note, plan of safe care on day of life 5, when they are like going for their 6-month visit, you're not going to go back to day of life 5 to look at that documentation. So the other thing that you can do, has anybody used the media, do a media picture or whatever in Epic? So Epic has a functionality, if you have it on your phone, that you can take a picture. It's great for like rashes. I love it for rashes. That's like my favorite activity, is taking a picture of rash. Or like infant stool, taking pictures of infant stool. The media tab is a wild place, but one of the things you can do is like you can print that out, take a picture of it with the Epic app, and then it goes and lives in the media tab of their record. That's oftentimes where, like, when people get their prenatal care elsewhere, it will often be uploaded into the media tab. So that's another way that you could like put it in the medical record, so it's easy to access, but it's still like in a secure place. And then you can just shred it. So we don't have like sensitive information. Let's see, what other things? What time does this end? I went way over. I'm like so sensitive now because I went way over in our last one. It started at 35. So probably
20.
Oh, 20. Okay, we've got plenty of time. Okay, cool. Okay, I think, so these are, do you guys want to see what the paper-based template looks like? Would that be helpful? So this is basically the, how do I make it bigger? So I basically took the document that lives in our medical record and just put it into like a Word document. And so again, this is the information that you would probably want to remind, either you redact or remind the family to scratch out if you're going to physically like hand this to them. So this has a brief place to document that infant's nursery or NICU course that again would be helpful if a family is following up with an outpatient pediatrician and that outpatient pediatrician does not have the same EMR. This is like a quick and dirty, what was this infant's course? That they can see. They don't have to rely on the family to tell them about, and they don't necessarily have to like sift through 18 pages of hospital records. We have a place that folks can document any substance use during the pregnancy that may then impact that child. As we were seeing earlier today, an infant, for example, who may have in utero alcohol exposure may not necessarily look or act differently than an infant who didn't during the first 5 days of life, but it's helpful for that pediatrician to know that this infant may be at risk for FASD so that they can make the appropriate referral to a pediatrician or a provider who can diagnose and then provide the appropriate services. Of course.
Legalization of psilocybin, was that something that you are monitoring more closely in the Denver system?
That's a great question. Not to my knowledge is a short answer. Lori Halmo is a pediatric toxicologist, so she may have a better answer to that. But I don't have a great answer. It's a great question though. I have not seen that extensively in my like clinical experience. I don't know the other folks who work in the newborn space. That has not been one of the top newborn exposures. Yeah.
So I have worked a lot in the supportive housing and harm reduction space. And one of the things about psilocybin is that people tend to use it very differently. In terms of, I mean, can you imagine tripping while pregnant? Like what? So people use it very differently, and there's gaps between uses. So a lot of people report if I use it and then I use it again within a couple of days, it doesn't really work. And so it's more of like an episodic use as opposed to constant use, unless you want to talk about things like microdosing.
Yeah.
Which
Oh,
is
interesting.
Another, thing that factors in class. And
I know there's like a whole national like mothers psilocybin group that I follow.
Oh.
If you're
are
interested.
they talking about like microdosing?
Yeah, a lot of microdosing, but also some higher dosing and just changing the stigma narrative around psilocybin being a hardcore anyway. And I just because it's legal here,
Yeah.
it's just such an interesting
It also
place.
used to cause nausea and vomiting, so I'm assuming it's not as much fun to take, I assume.
And this group is just a group of people. I mean, there's no.
Oh,
medical
interesting.
people in it.
Yeah. Oh, interesting.
Yeah.
I think that will be like, just sort of as we've seen, like, the downstream effects of like legalization of THC containing products. And now like the discussions we're having about cannabis and lactation and things like that. I wonder if we'll see this in like a couple of years. Yes, exactly.
Thank you.
Yeah. Thank you. Okay. So, here is a place to document if the infant had any sort of toxicology testing done. Wanting to reiterate the fact that this is not required. And we truly, I don't know if any of you guys attended the toxicology testing breakout session, but we are really trying to like kind of move away from that. An opportunity to, for oftentimes our social workers are the one that are filling this out, who lives in that household and who are supportive to that person. One thing that when I was creating this, that Dr. Klee's patient had recommended is including documentation of whether or not the folks in the home are safe or sober, which is something that I did not think of, but is I think is helpful to know if you're talking about creating a sober caregiving plan with a family, if you're talking about safety of that infant in the home, if there are other folks in the home who are actively using substances, it becomes a different discussion of sober caregiving and safe storage of substances. So I appreciated the feedback that she had of one of her patients of documenting that.
Who's reporting the safe sober part?
So this is being filled out by our social worker sitting next to the family in that hospital room.
Is the social worker's assessment or the?
It's the social worker asking who lives in your home.
Yeah.
Are those individuals currently using substances?
Both
Are they
parents.
safe? Yes.
Okay.
Yeah. Well, so Yes, often, yes.
Maybe.
Yes. We can only, I guess, kind of document what our families feel comfortable sharing. And so I think, I've had some families who have been very forthcoming and saying, hey, I'm going to go back and I'm living with my mom, and my mom is like actively using. And so it's helpful to know that, so that, we can then help support that person going home to that environment. But I recognize that folks may not always feel comfortable sharing that information with healthcare providers. So, and then, so this is, I think, what is often most time consuming during the birth hospitalization. And this is often, filled out by our unit social worker or care manager. So they are, again, sitting at the bedside with these families over the course, oftentimes, of many days during the birth hospitalization, and doing a needs assessment of what are the current needs of that family, what services are currently in place, and where are those gaps that we can, as the healthcare provider team, can help fill those gaps. And so one thing that I think I kind of want to point out here is we have had some families who have had previous involvement with the justice system, and so offering resources. So I really like the Office of Respondent Parents Council, so they can really step in and help support families. Making sure that the families have an early intervention referral. So one thing I'll give a shout out to Mandy Langer. She was the mom baby social worker at Denver Health. And she helped me sort through this. She was the one who came to me and was like, yo, I don't have access to fill any of this out. So I was like, okay, cool. We need to fix that. And when she is now with the CHIP clinic at Children's, but when she was on our unit, we had an almost 100% early intervention referral rate for our infants with in utero substance exposure. So shout out to that, and also a plug for having a champion somewhere in your unit that can really kind of carry that torch. A reminder about ensuring that family has access to Narcan. And then a reminder to offer peer support services if that's something that they are interested in. So this is not by any means an exhaustive list, but I think sometimes can be helpful as a reminder of what resources are out there and what may be helpful or supportive to families. And then, so this is the place where we as the nursery team can kind of document the plan for going home. And I think this is really important as a reminder, especially to nurseries, where folks kind of come in and out, is a reminder of what do we need to talk to these families about, absolute bare minimum when we are doing our discharge education. Another thing that I see come up is infants with who are diagnosed with NOWS or NAS often will have difficulty feeding. And one of the things that the outpatient pediatric providers really follow closely is weight gain. And I have had a couple instances where a baby had their formula fortified such that it had a higher calorie concentration in the nursery than what is normal. And that family went home and wasn't mixing the formula well, or didn't know that they were supposed to be feeding the extra calorie formula, and that baby gets discharged and all of a sudden they're not gaining weight. And what's really important is as the outpatient pediatrician, what was that feeding plan and what is my family doing? Because is it a matter of it was just a complete miscommunication and they just didn't know that they were supposed to be mixing this formula to a higher calorie concentration? Or is there a concern that perhaps this baby is not thriving on the recommended feeding plan? Or do I have concerns that this family, for whatever reason, isn't able to meet the needs of this infant or to provide for the care of this infant? So I think that's a really important thing. And I've had feedback from outpatient pediatricians that that's a really helpful thing to have. There's a spot for any medications that baby is going home on. This is an opportunity to ensure that birthing person has a follow-up with their OB provider. When is that? Do they have follow-up at a treatment program? And that's this is a place so that when that infant shows up to the pediatrician's office and their social worker pops in, we all are on the same page of like when that person was going to follow up and what support they have. So we're not doing our best to like not lose kind of people or making parents like rehash all of the things that all of the resources that they have had, all the referrals that have been made, like it's just in one place. Again, another plug and another reminder to ensure that this family has Narcan available, and then opportunity to list who that PCP for the infant will be, when is that follow-up appointment, and has someone given some sort of handoff to that pediatric provider. As I'm sure, the folks who take care of infants with in utero substance exposure during the hospital can attest to, and our outpatient providers, these are often pretty medically complex babies, and they've had kind of a long hospital course. They oftentimes may have a complicated psychosocial history. And so actually having that conversation or that epic inbox between your in-house provider and the folks following this family can be helpful. Any follow-up needs for that baby. So oftentimes we'll have a baby with a murmur in the nursery and that baby needs to be seen by cardiology in like 4 or 6 weeks. But in these discharge summaries that are 87 pages long, that is a very easy thing to get kind of lost. And so this is like the one place that you can go and say, okay, what is this feeding plan? Who do I need to talk to? Who does this family need to see? What do I need to follow up on? And then finally, a place to make sure that we are having the discussion with families, that we are creating this plan of safe care. This is, it sometimes is a surprise when they are handed this. But because we are talking about this and communicating with them the whole time, oftentimes when I'm handing them this, they're like, oh yeah, we've been talking about this. They just didn't know that it was called a plan of safe care or whatever. Okay. We now have 5 minutes left. In typical fashion, I get all excited and talk about all these things forever. Any questions about that or any?
I just want to make a comment. It just brought to my attention. We see a lot of moms come back with their baby and there's no plan of how they're getting formula, how they're getting diapers, that they do help with setting up those processes, but parents don't know how to follow through. Or moms rationing out the formula because they don't know where the next can's coming from.
That's really helpful to hear. I think at least on our, on the Denver Health, like mom baby side, they will put like when the next WIC appointment, we have the luxury of like WIC coming and seeing our families in person. And we'll say, hey, we're scheduled to see you in X amount of days to get to have your, intake appointment or whatever. But it's helpful that is like heartbreaking to imagine that families like have to feel like they have to like ration that.
Yeah, and we try and get them with their WIC appointment to make sure I'm in a treatment center, and make sure if they're in a session, we're pulling them out. But if they have to wait 5 or 10 minutes for us to go get them from their group, they hang up, and then it's,
yeah,
it's heartbreaking.
And that's one, I think, like when maybe like learning point for hospitals. One thing that I try to do when I'm like discharging folks is saying like, hey, when is your WIC appointment? Like, when can you do you have A, money to buy formula until your WIC appointment? And B, do you have a way to get to King Soopers or whatever? And I have had many families who are like, no, I don't. And so I'm this is probably like against the rules of Denver Health, but like I just go into the like supply closet and I'm like, here's like formula to get you like through. Because then what we'll see is that then folks are rationing formula, and so they're mixing it with a different, they just do 1 scoop for 2 ounces of water or whatever. Yeah, exactly. So yeah, thank you for that. That's like heartbreaking.
Community partners.
Yeah.
Begging for.
Yeah.
I mean, that's what we do.
Yeah.
Like that drive that you
Yeah.
guys are doing for us, because we spend a lot of our donations on just getting formula and
Wow.
diapers for these moms. So
Wow.
they're not, instead of a newborn having 10 diaper changes, they're having 3.
Oh.
And then they're wondering why, they got bigger health issues.
Right.
So.
Well, and especially with our babies who have neonatal opioid withdrawal syndrome, they are often the babies, they need their diapers changed. I mean, when I am taking care of them in the nursery, they're getting their diapers changed I mean, like dozens of times during the day, because they often are stooling more often. That stool is like irritating to their bottoms. And so if they're sitting in that stool for longer, that then like further irritates their bottoms. You can tell I'm a pediatrician because I say bottom.
I can say from my perspective as an outpatient pediatrician, both in a general pediatric clinic and then also in a clinic that almost exclusively sees babies that are exposed to substances in some way. We don't get this information. I mean,
and that's the feedback that I have received from.
so we get like 50-page discharge
Yep.
summaries and like a sticky note worth of
Yes.
information in
Yeah.
it. None of it including what the feeding plan is or what the discharge weight was or like what substance
Yeah.
they were exposed to. So then we're being asked like, well, what's the long term? What can we expect? I haven't thought of it.
Yeah. And that's one of the, I did,
And they're not being referred to early intervention. Or there's no evidence.
yeah.
And they're not.
That's one of the, like the feedback that I have received, because I like surveyed some of our outpatient pediatricians about like, what is helpful? What information do you get? What information do you not get? And that was one thing that they were saying is like having all of this in one place, including like, I know the WIC referral was made because the follow-up appointment is here. And like, I know the early intervention referral was made because like the number was here. And like, so I think that like, that's exactly the feedback I got from the DH folks, with the caveat that at least at Denver Health, this is showing up in the discharge summary. And a lot of times these discharge summaries for the babies are 50 pages long. And then the term like note bloat is like thrown around, where like there are like 18 million problems, and like how do you find the relevant information to take care of this baby and this family? And so that has been some of the feedback I have received from the pediatricians has been like, can I just get this? Like, I don't want this. I don't need the whole discharge summary that's like 80 pages. Just give me this. And so I know like a lot of the babies from the university will often wind up at like some of the CHC clinic space. And so they're like creating this in like a separate note.
This is huge, because even them going to a treatment center, for the treatment center to know this plan, I mean, why would we start all over and do it again?
Exactly. Right.
Well, and if
And
we
I've
talk
never seen
prenatal, our treatment centers could develop this prenatally and then take it to the hospital.
Oh yeah, exactly. And I mean,
When they come in,
Right.
But if they go to the hospital first and come to us from the hospital, we're all doing double duty.
Oh, exactly. Well, and I think acknowledging the fact that like talking about this and like doing like a needs assessment or resource assessment is not an atraumatic experience. So if I'm asking somebody, do you need a referral for DV services? The underlying question is like, are you a survivor of intimate partner violence? And that question in and of itself is like, that is a traumatic thing to have to talk about and have to share with the provider. And then to tell your mom baby social worker, like, yes, I am in an abusive relationship and I need help. And then to go to your follow-up and they're like, oh, so like, tell me about your trauma. That like, if we can minimize, and I have seen this, like, we have a perinatal SUD kind of care navigator who does intakes that are similar to this with our perinatal SUD population. And asking these questions is like a traumatic thing. And it asks folks to like share a lot of vulnerable traumatic experience with people they don't even know. And why would they trust us? And then to ask them to do that multiple times, all in the name of like helping support them, is a tough ask. And so that's the other, I think, beauty of this is like, can we just do this? Can we like minimize the amount of times we're doing this and also not be duplicative of if a referral has already been made to like Rosandum, we don't need to then go to our treatment facility and have somebody else make another call. Like that also then clogs the system. And so yes, that's kind of the hope. All of these, so I have these on paper as you can see in like my janky, just like Google Drive, and also the templates that could be put into Epic. So if anybody like wants copies of these or whatever, feel free to email me. And then the other thing is that when our Plans of Safe Care work group was putting together our best practice guidance and also that little one pager, we created a survey on the website where you can get that. If folks want more support that is like organization or institution based. So another plug for that QR code. It's just a very like painless survey that is like, what is your name? What is your organization? How would you like support? And then we as the work group are going to gather all of those, all of that information and kind of figure out what do people want. And then we'll either do like lunch and learns at your institution or put together toolkits, whatever it is that the people want. Cool. Well, thanks everyone for your time. Thanks for taking care of our friends.